think most of us know Dr. Zamora. He was our clinic doctor here, and he conducted the research project that he's going to give us a report on today. Okay, let's put that in your pocket.
Oh no, drop that. Got it. Is this good right here?
That's fine.
Okay.
Well,
Thank you. Thank you very much. It's great to be here. It's such a privilege to see you all again. Sounds like you have wonderful things come along with this new menu. I think last time I was here, I gave a talk about hypertension, high blood pressure, and how as Americans we eat too much salt. So this is great. But so I wanted to come talk to you about the temperature patch study that many of you were involved in. And let me just tell you how grateful we are to you for your support, participation, your enthusiasm. We really couldn't have done it without you. I think it helps to have that relationship between people and Bermuda Village and have us here on site. I'm not sure if we would have been able to achieve the same success going to another facility where they didn't know us. So it's been really, really wonderful, and I know the Verity folks have been really appreciative as well and excited. They love hearing the stories that I go and I tell them about somebody fishing a patch in the pool, and but I think it's been a really fun project. Thank you. So let me begin by giving you an introduction, and I'll give you some background, and we'll talk about the study itself and give you some results. Wanted to let you know that this week we are submitting the manuscript for this study to the Journal of the American Geriatric Society. This is really exciting. So some of the not allowed to disseminate any of the graphs and stuff. So really appreciate if you wouldn't take pictures and post them on social media. We'll get in trouble, okay? I'm sure you understand. Thank you. So as you know, and I think we've talked about this a lot before, residents of congregate living facilities are susceptible to infection. This is due to an in the host immune system. Problems like kidney disease, high blood pressure, heart disease, poor nutrition, medication, especially that affect the immune system, like prednisone, frailty, of course. So it turns out that infection is a leading cause of hospitalization. And so I went back in 2018 and I looked at the 10 most common diagnoses for inpatient stays for adults greater than 75 years old. And the first one was septicemia. So organ failure secondary to infection, a very serious life-threatening condition. And then it was followed by heart failure, but then look again, pneumonia, heart rhythm disturbances, arthritis, and then urinary tract infections. And that was followed by kidney failure, stroke, hip fractures, and heart attacks. Interesting where heart attacks goes now. It's number 10. So, such individuals tend to have a more severe illness course. They're higher mortality rates. They have higher mortality rates compared to younger patients. These individuals are susceptible to a decline in health and functional status, especially after a prolonged ICU stay in the hospital. Many folks will be discharged with a new disability, and they won't be able to go home after the hospital and will have to go to a place like next door to get some rehabilitation and get strong again. And I pulled this up here, and these are the death rates of infection, depending on the age group. And you see here clearly, the older you get, the higher the mortality. It seems like once you hit 60 years old, the mortality really jumps up. This is the overall average, the 0.5 to 1%, but in that average, it's definitely older adults who have the highest mortality to infection. We've all seen that the current COVID-19 pandemic has had a detrimental living facilities. We know about, or I remember hearing about back in March of 2020, that nursing home in Washington State where 33% of the residents there infected with COVID died. And I recall there was a fair number of staff members that got infected as well. I don't recall the number, but it was significant. It's interesting because older adults reside in a long-term care. They account for less than 1% of the U.S. population, however represented 31% of COVID-related deaths as of August of 2021. And this was actually higher prior to the vaccine rollout. So, with this, it led to aggressive measures, things that we instituted here, if you recall, to keep people safe. We had visitor restrictions, and we had temperature monitoring, and people having their temperatures checked up there in the front. We try to get people not to congregate, and I know that was really, really, really tough. And of course, we were doing things to detect fever, which back then I was medical director of over here next door, and one of the things that nurses would do was monitor for symptoms. The classic symptoms, the shortness of breath, the cough, the fevers, feeling ill, getting confused, all these things, pain, chest pain, all these things that could point to infection. And of course, the nurses had, or they were checking temperatures, I believe, every shift. Typically, and this is based off of CDC guidelines, if they had a temperature greater than 100.4, they would be screened for COVID. They would give a COVID test. But it was following that threshold of 100.4, and I believe they still use that. The problem, though, is that older adults can have an atypical presentation of infection, especially with temperature elevations. Studies have reported that nursing home residents tend to have lower and more variable basal body temperatures and are less able to mount a febrile response. I remember when I was in training, they used to teach us that a 2-degree increase from the baseline on consecutive measurements could be considered. Meaning if your baseline was 97 and somebody had various temperatures of 99.2, that should be considered a fever. And fever may be absent in 30 to 50% in frail older adults with serious infection. I wanted to share 2 articles that were published last year. This one from the Journal of the American Directors Association. And in this study, they took 453 veterans residing in nursing homes. And check this out. Those infected with COVID had an average maximum temperature of 99.8. 99.8 compared to 98.8 with those without COVID. Only 26.6% of those with COVID met the fever threshold of 100.4. So potentially, these folks, So about 3/4 of them didn't have that fever threshold, probably didn't get tested. And they said that 20% had no temperature deviation from baseline. And get this, that temperature had an increase from baseline 1 week prior to testing positive for COVID, meaning that the temperatures were going up, didn't quite meet that baseline 1 week before, meaning that they were possibly transmitting infection to others, right? Here's another study, and this was another reputable journal from the New England Journal of Medicine. And they reported that of 89 residents, 57 tested positive for COVID. 56% of those were asymptomatic at the time of testing. Yet, 24 of them subsequently went on to develop symptoms, 11 of which were hospitalized, 3 were admitted to the ICU, and 15 died. Okay. So currently the CDC recommends daily temperature assessment in nursing home residents. But usually, the nursing screening tools that they use usually has that threshold temperature of 100.4 to determine a fever. The problem with having this universal temperature cutoff is the potential to miss the smaller but clinically significant temperature increases. Right? And you would fail to detect infection early on. So we believe that taking an individualized approach to monitoring temperature trends would likely lead to earlier detection of infections like COVID and others. We hear about outbreaks all the time occurring in facilities. Neurovirus, we were just talking about earlier with somebody next door at the gravestone in the springtime. So, what do we do about it? So here's you guys remember this, the Verily patch. And this is a patch. It's quite small. It's about the size of, a quarter, you think? Something like that. And it's a patch that fits into this adhesive, and it's placed here under the armpit. My understanding is that most people forget that it's even there. Is that true? Yeah. You really don't feel it, but it's there, and it's monitoring or checking your body temperature every 30 seconds. And it's transferring that data to a cloud and to your smartphone. You guys remember that? You can look at your smartphone and you can see you can check out your body temperature. As a matter of fact, if I recall, you can even set it so it would give you an alert if you had a temperature greater than 99. I remember setting that up for you guys. So this technology has been applied in the bone marrow transplant unit for pediatric and adult patients previously to this, and they showed an earlier detection of fever. So we wanted to test the ability of that here at a facility like this. So our central hypothesis is that a small wearable patch that continuously monitors body temperature will be more effective than daily manual temperature assessments for detecting early COVID and other infections, leading to earlier treatment and instituting measures to prevent transmission. So what we wanted to do was determine the feasibility of this technology, of this T-patch here or at a local congregate living facility with residents from independent living, assisted living, and staff. And so that's where we came to you guys. And I wanted to show you guys our team. Of course, the Verily people that I think you may have talked to once or twice on the phone, possibly. And then there's Scott, the coordinator. Scott is back there. You remember Gina, who did the recruitment early on. You guys remember her? She was a lot of fun. And then this is Eric, who's sort of the brains. Then, of course, my boss, Dr. Williamson, who's the boss. And then they let me tag along too. Oh, absolutely. Absolutely. And look at this. Look, this is all subliminal. Look at this Bermuda Village on top of Jeff. Jeff's always thinking about you guys. Yeah. Oh, yeah. He wanted to be here today. Looks like he has some meetings, unfortunately, but I can tell he really, really wanted to come by, and thank you personally for your participation. Oh, was it? I'll let them know that. I'll have to tell them that. So that's our team. Okay, so regarding the methods, we selected 35 participants, 25 residents, and 10 staff to wear this continuous temperature device here in the armpit. The residents came from independent living and from a catered and enhanced living. I really wanted to recruit from Greystone building, and unfortunately was unsuccessful. I think some of the limitations were cognitive impairment and not having a smartphone. The recruitment, we did in person, and as you recall, I think I came here and spoke to you guys after I think a statistician gave you guys a talk about COVID, and then of course Marvin, and you guys just were instrumental in promoting this. I really appreciate that. So the exclusion criteria was diagnosis of dementia, current active infection or fevers. And then if you guys recall, we checked a COVID test. That was part of the things that we did for signing you up. Non-ambulatory, obviously, if you did not have a smartphone, an iPhone, or an Android, you couldn't participate. And of course, a history of adhesive allergy. So this took place over 3 months, and first day of enrollment was March 25th, and it was concluded on July 13th. And so on site, we gave you some training, consented it, and we were right across over there at the pub doing this. I remember telling the Verily people, "Yeah, we're doing it at the pub." "What? The pub? That's where we go." They didn't quite understand. They thought I was taking you guys to the bar. But yeah, we had that little temporary office over there. And the study coordinators and myself, we would assist with downloading the Verily app on your smartphones and pairing it and placing the T-patch on that day. The participants wore the device continuously, and they changed it every 3 to 7 days or as needed. For some, you had to change it a little bit more often. Others, I think, made it to 7 days. And also, participants were asked to check their daily temperatures manually with a thermometer that we gave. Research staff reviewed the temperature data, with that cloud every day. Make sure that there were temperature measurements, and if there wasn't any, I think you would get a call from either Scott or from Jen, and they would kind of troubleshoot and see what was going on. So what were our outcomes? So the primary outcomes were participant adherence, ability to self-apply the device, overall availability of the data, and then the secondary outcomes were we wanted to compare the temperature data between the T-patch and the manual. Okay, those were the things that we were measuring. And so the demographics, total number of participants, like I said, it was a small number at 35. 10 were staff, 25 were residents. 23 came from independent living, and we had 2 from catered living and enhanced care. In the independent living, there were 9 males and 14 females. In assisted living, there was 1 male, 1 female. And I think with staff, all were female. The mean age was, with staff, 33.9, and in independent living, it was 81.9 and 84 for enhanced living. All were Caucasian with resident participants. And then, or as a smartphone, half were Androids, the other half were Apple, whereas the staff seemed to favor Apple over Android. So our results, this is what we've been waiting for. So in primary outcome, looking at the percentage of people who completed the study. All right, so this is the percentage of all users, residents and staff. You want to take a guess? What percentage completed the study? 85, 95? Wow, you guys are optimistic. That's good. Yeah. So just to let you know, what our ideal cutoff, what we determined to be a success was we were aiming for residents to be greater than 90% and for staff to be greater than 80%. So you said 85, 95. Yeah, so it was 85.7, which is pretty good. It was actually really, really good. That was in total. Now, the percentage of resident participants completed the study, you guys, what do you think that was? 95? 95? Yeah? That was 80%. But that's good. Oh, no, that's really good. It's very close to our 90%. It really is. And the reasons, anyone want to guess what the reasons for dropout were? Yeah, fell off in the pool. Yeah, going fishing in there. So one device was lost by the participant. No, she got it. She swam in there and picked it up. Scuba dived and got it. We had some connectivity pairing problems with another device. There was a case of skin irritation, unable to sync the mobile device phone, and an unrotary. But these were the 5 reasons there, which isn't bad. Okay. And looking at the percentage of users able to reapply the device adhesive without assistance, this was also really good. I know that, so we had set the ideal cutoff at 80% and for staff greater than 90%, and 93.3% of the residents were able to apply the device on themselves without assistance, which is important, which is really important. If it happens to fall off in the pool or wherever, that you're able to put this back on. So yeah. Looking at data availability, the T-patch provided temperature readings 99% of the wear time, which is what one would expect. As far as the manual readings, well, get this. So I thought this was fascinating. So there's about 2,000 manual temperature measurements across all participants, compared to 6.6 million measurements that the device made. Isn't that pretty wild? That's a lot. So there was some issues there with some temperature. So about 10%, they were physiologically improbable with the manual ones. People were recording temperatures of 93, for example, which wasn't, it just wouldn't be plausible, or you'd be dead. So yeah, we just had some very extreme temperatures that were unlikely. I suspect just related to maybe you pulled it out too soon without waiting for it to continue registering. But the manual temperature compliant, worse were the staff. They only checked at 32% of the days, which I would expect. They live very busy lives. Whereas the catered enhanced residents, well, it was 100%, but there's somebody over there checking their temperatures every day. And then with independent living, it was 54% of the days. And so we're going to look at a little bit of, I'm not a statistician, we'll just touch on this, but there was, for the manual measurements, The median was 97.3, for staff at 97.2. For the resident participants, the median was 97.3. That was again for the manual measurements. The continuous temperatures are a little bit higher. Their median was, for the staff, was 98.2, and for residents it was 97.9. What was interesting here, if you compare manual temperature measurements with the Verily patch readings, you'll see a greater distribution of values here following that Bell's curve. I think there's more noise, so to speak here, more variability, whereas a lower median compared to the Verily patch where it's a lot closer to the median. There wasn't as much variability. So here is interesting. Okay, so fever was detected in 4 participants. What was interesting was that none of these participants had a fever recorded in their manual temperature checks. Yeah. And I got 3 of these right here. This first person, this one right here, they weren't checking their temperature. But all these right here, this is 100, this is 101, this is 99, 98. You can kind of see it's sort of bouncing around, and then you get a little temperature right there. Looks like it might have been about, maybe about 100.5. A little spike right there. And look how it just kind of comes down again. Now this one is really interesting to me. See these little red dots? That's when they checked their temperature. That's where they checked it manually. And look at this. They checked it manually right here, and it was normal for them. And then they get this temperature spike, again, probably close to 100.5. And look at this. They check it again over here, and over here. And they missed the spike. This is daily. Let me see. Yep, 6'8", 6'9", 6'9", 6'10", 6'10", 6'11", 6'11", 6'12". Right. That's fascinating. And then here's somebody where they didn't record it, so they didn't record the exact time that they took the temperature. But you can see here how you had a spike, and this one was close to 101. So here. There's a man right here. So I think some you and right, Scott, you and
well, because this is all retrospective, you didn't realize it at the time, and so all of this is captured after the fact. But ideally, if it had been a sustained fever, then it probably would have picked up on one of those manually. So that's why this is a feasibility study, kind of looking retrospectively. The intent of this is to have it be real time, actually. So hey, someone's monitoring this, that report goes to the central desk, hey, you can see the spike, let's go check.
Yeah. Right. Yeah. You want to talk in the microphone here so everyone can hear you? Oh. Oh, here we go.
Yeah, I was one of the ones who had a fever. I had a sinus infection, and I didn't notice it with the patch, and that's how I figured it out. In fact, I used a patch rather than using just a manual thermometer, so I don't know which one of these may not be one of these here, but it picked it up, and I was really amazed that it did.
Yeah. Oh, that's cool. Then you're able to go to your primary care doctor and get antibiotic. Yeah. Well, I think I love this data here. I think it's fascinating. It tells you a lot. Please, absolutely. You want
to? Is the patch immune to external temperature other than body temperature?
Right, and so the patch is able to sense fluctuations. For example, if you're taking a hot bath, or if you decide to dip